Improving Compliance of Alcohol Impregnated Caps, The Change Project, by Lindsay O'Donnell. The aim of this project is to improve compliance of alcohol-impregnated caps and increase the usage to include peripheral IVs. Give the patients confidence in care by teaching them self-advocacy for disinfection. My inspiration is that there is a need for reinforcement of alcohol-impregnated caps, compliance in central line, and initiation of AICs for peripheral IVs. Currently, our hospital does not have the caps for peripheral IVs. A review by Morrow and Flynn in 2015 evaluated that 140 studies and 34 abstracts on NC disinfection practices, the impact of hub contamination on infection, and measures of education and compliance results. The greatest risk for contamination of the catheter after insertion is the NC, with 33 to 45% contaminated, and compliance with disinfection as low as 10%. The optimal technique or disinfection time has not been identified, although scrubbing with 70% alcohol for 5 to 60 seconds is recommended. Studies have reported statistically significant results in infection reduction when passive alcohol disinfection caps are used, a 48 to 86% reduction. 4 themes were identified from Bishop and McDonald in 2017 findings by patients. Number 1, the patients wanted control. Number 2, the patients wanted to feel connected. And number 3, the patients felt like they were encountering roadblocks. And number 4, they wanted to feel like they were sharing the responsibility for safety. Both patient and nursing staff participants highlighted the importance of building a personal connection as a precursor to ensuring that patients are involved in their care and safety. However, perceptions of provider stress and nursing staff workload often reduce the ability of the nursing staff and patient participants to connect with one another and promote involvement. With Duncan and Warden in 2018, a compliance rate of close to 90% with the use of the disinfectant caps and tips was attained. Using a plasmid bundle successfully decreased primary bloodstream infections due to PIVs. We confirmed that improving care for PIVs would decrease primary bloodstream infections associated with these devices. The outcome: patients will feel empowered after being educated on line disinfection. Patients will have the tools and education to self-advocate for disinfection measures. Also, outcomes include decreasing central line infections, increasing patient education, and make patients feel comfortable advocating for themselves. The responsible party for this implementation is myself, Lindsay O'Donnell, a nurse at Sisters Hospital. This was obtained through several shifts in July 2018 at the location of Sisters Hospital on 4 West. Nurses, patients, and family members all work together in collaboration. The steps for implementation including 1, the patient surveys, 2, educating the patients, 3, resurveying patient lines, and 4, resurveying the patients. The expectations are patients will verbally identify an increase in confidence in care via anonymous survey that was given. The patients will be more educated on disinfection methods in related to IVs. The patients will feel comfortable advocating for themselves for placement of AICs or swabs. I expect when the patients verbalize the importance of using AICs, nurses will become more compliant with the policy and ultimately see a decrease in line infections. The results. Prior to education, 20% of patients said they didn't realize that disinfection was important when using IVs. Unfortunately, 40% of nurses are not always disinfecting ports. 90% of the patients feel they cannot speak up if their nurse didn't disinfect the port. This shocked me, and I had to ask the patients why. Most felt that their care would be negatively impacted if they questioned the nurse. Again, this is why patients didn't feel comfortable questioning. After the education, the results were quite the turnaround. 100% of the patients now knew their IVs must be disinfected. 95% of the patients now said their nurse were disinfecting ports because they were questioning the nurse if they didn't see the disinfection. 100% of the patients felt that they could speak up. However, 60% of the patients felt comfortable questioning the nurse, but that leaves 40% of patients feeling uncomfortable questioning the nurse. The pre and post evaluation showed significant improvement in patient education on the importance of disinfecting IVs. The data also showed an improvement on patients' confidence for self-advocacy. Overall, I would say that the implementation of education on disinfecting IV ports was a success. Statistically, there was a significant improvement on patient education and confidence for self-advocacy. Improvements. To improve the project, it would be best to implement over a longer period of time. As a float RN, it is hard to implement by unit because every shift I work at a different floor. Aside from my own limitations, I could broaden the patient focus by educating on other important topics and encouraging patient self-advocacy, for example, hand washing, daily bathing, palliative care, and consults. These are my 3 literature references that support my implementation of nurses complying with the disinfection of any IV tract.